Welcome to this episode where we're diving into pediatric respiratory conditions, focusing on the unique vulnerabilities of infants and young children, and how that shapes both assessment and management.
Yeah, it's a critical area, especially because the anatomy and immune system of kids really set the stage for how infections develop and progress. I mean, infants aren't just small adults. Their airways and defenses are fundamentally different.
Exactly. One of the key risk factors that often gets overlooked is exposure to secondhand smoke. It's a major modifiable factor that impairs mucociliary clearance and weakens immune defenses, making infections more likely and more severe.
Right, and when you combine that with their naturally smaller airway diameter, even a little inflammation or mucus can cause significant obstruction. Plus, the shorter distances between respiratory structures mean infections can spread rapidly from the upper to the lower airways.
That's a good point. The continuous mucous membrane lining acts like a highway for pathogens, so a simple cold can quickly escalate to bronchiolitis or pneumonia. It really underscores why we have to be vigilant for signs of progression, not just isolated symptoms.
And the immune system plays a big role too. Infants rely on passive maternal antibodies that fade after birth, leaving them more vulnerable. Plus, their eustachian tubes are short and open, which predisposes them to middle ear infections and facilitates pathogen migration.
So, when we're assessing these kids, it's not just about counting respiratory rate. We have to look at depth, rhythm, oxygenation, hydration, temperature, activity level, and importantly, their comfort level. That last one is subtle but critical. It often signals respiratory distress or fatigue before other signs become obvious.
Absolutely. And speaking of signs, inspiratory stridor is a hallmark of upper airway obstruction, indicating edema or narrowing at the laryngeal level. That contrasts with crackles, which point more toward lower airway or alveolar involvement.
That distinction is crucial clinically. For example, in croup, which is the most common croup syndrome in kids under 5, you'll see that classic barky cough and inspiratory stridor. It can progress to respiratory failure if severe, so early recognition is key.
And then there's epiglottitis, which is a true emergency. The 3Ds mnemonic drooling, dysphagia, and distress, along with tripod positioning, really helps differentiate it from typical laryngotracheobronchitis. But importantly, you should never try to visualize the throat in suspected epiglottitis, because that can worsen obstruction.
Yeah, airway management takes absolute priority there. On a related note, bronchiolitis, most commonly caused by RSV, affects the small airways and leads to inflammation and obstruction. It's a major cause of hospitalization in young children.
And acute otitis media often accompanies these respiratory infections. It's important to distinguish it from otitis media with effusion, since AOM involves acute infection signs like fever and ear pain. Antibiotics are reserved for severe cases, especially in infants under 6 months, or those with high fever and significant otalgia.
Infants can't verbalize ear pain, so we look for behaviors like ear pulling, fussiness, refusal to feed, or even rolling the head side to side. These subtle signs are often the only clues.
When it comes to nursing interventions for mild respiratory infections, supportive care is the cornerstone. Rest, hydration, infection prevention through hand hygiene, and saline nose drops with suctioning for infants. Routine use of OTC decongestants in kids under 6 is discouraged because of limited benefit and potential side effects.
Post-tonsillectomy care is another area where vigilance is essential. Continuous swallowing is the earliest sign of bleeding and demands immediate attention. Positioning the child side-lying or prone until fully awake helps drainage and reduces aspiration risk.
Also, avoiding red or brown fluids initially is important, so blood isn't masked. And milkshakes or other milk products are best avoided early on because they coat the throat and can trigger throat clearing, which might precipitate bleeding. Pain control and monitoring for tachycardia and pallor are also key to catching complications early.
Shifting gears to asthma, albuterol remains the classic quick-relief medication for acute bronchospasm. But long-term management is multifaceted. Avoiding triggers, teaching correct inhaler technique, and adherence to controller medications. Exercise isn't stopped permanently. It's managed appropriately.
Status asthmaticus is a life-threatening emergency, persistent severe respiratory distress despite treatment, with risk of respiratory failure and death if untreated. Early recognition and aggressive management are vital.
On cystic fibrosis, it's important to remember it's a multi-system autosomal recessive disorder affecting pulmonary, gastrointestinal, endocrine, and reproductive systems. Pulmonary involvement includes thick secretions and chronic infections, while GI manifestations include pancreatic fibrosis leading to malabsorption and those classic large, bulky, foul-smelling stools. When assessing respiratory distress or impending failure, we look for nasal flaring, retractions, grunting, stridor or wheeze, cyanosis, and head bobbing. These signs indicate increased work of breathing and poor oxygenation.
Respiratory failure happens when these compensatory mechanisms fail, requiring urgent intervention. Interestingly, respiratory arrest in children has a better survival rate than cardiac arrest, which highlights the importance of early respiratory support.
Before we wrap up, a couple of clinical pearls. Apnea is defined as no breathing for more than 20 seconds or shorter if accompanied by cyanosis, pallor, or bradycardia. Choanal atresia presents with cyanosis at rest that improves with crying, and congenital diaphragmatic hernia can be suspected with bowel sounds in the chest, diminished breath sounds, a scaphoid abdomen, and severe respiratory distress.
Those are great reminders. So to sum up, pediatric respiratory conditions require a nuanced understanding of anatomy, immunity, and environmental factors. Assessment goes beyond just respiratory rate to include comfort and activity level. Recognizing classic signs like the 3 Ds for epiglottitis, or the barky cough and stridor of croup can be life-saving.
And management hinges on supportive care, careful monitoring, and knowing when to escalate, whether that's antibiotics for severe otitis media, emergency airway management in epiglottitis, or aggressive treatment for status asthmaticus.
Exactly. It's complex but rewarding work, and having this detailed knowledge really enhances clinical acumen and patient outcomes.
Thanks for joining this deep dive. We hope this discussion sharpens your understanding and supports your practice in pediatric respiratory care.